Biomedical's webinar this evening, the first in our medical education program of 2025, on behalf of Nova Biomedical Australia and New Zealand. My name is Steve Mordit. I'll be your moderator for this evening, and I'm talking to you from New Zealand. Kia ora. We will be joined this evening by our speaker, Dr. Masaru Yamamoto, who's joining us from Tokyo. Today's presentation is with regards to the clinical utility of ionized magnesium for patients in critical care. A couple of points of housekeeping. This presentation in total, or this meeting, will last approximately 60 minutes. The presentation is approximately 35 minutes, and then we'll allow 15 minutes for questions and answers. On your screen is a function for you to ask questions. Please, as you're hearing the presentation, if you wish to raise a question, if you would type it into that box, those questions will be seen by both myself and Masaru, and we will address those during the Q&A session at the end of this presentation. The presentation that you're about to see has been pre-recorded. The question and answer session will be live, and our speaker is with us throughout this presentation. So I'd like to introduce our speaker for this evening. That is Dr. Masaru Yamamoto. Dr. Masaru Yamamoto obtained his PhD from the School of Chemistry and Biochemistry at the Georgia Institute of Technology in Atlanta, Georgia. After going back to Japan, he worked at Kwansei Gaiken University in Japan, and then switched his career to an industry pathway, having conducted research at the Research Center in Kyoto, Bayer Yakuhin, and Sakagaku Corporation. His career appointments have also seen him undertake various positions, including managerial and leadership roles within various organizations. Masaru holds membership with the Society for Critical Care Medicine, American Chemical Society, American Association for Clinical Chemistry, Japan Society of Clinical Chemistry, the International Communication Committee, and the Japanese Society for Magnesium Research. Masaru has published extensively on topics relating to point-of-care testing, blood glucose and ketones, analytical evaluation, and measurement of ionized magnesium. He's also presented internationally on these topics, in particular on the role of ionized magnesium in clinical settings and monitoring and detection of ionized magnesium levels using blood gas analyzers. I will now present the presentation to you. Please add your questions as you find them, and we will join you again for questions and answers shortly.
My name is Masaru Yamamoto, Director for Asia Pacific, Medical and Scientific Affairs, Nova Biomedical. Today, I'm going to talk about magnesium. This is COI. I'm a paid employee of Nova Biomedical, and my presentation is intended to be educational and free from commercial content. Today's goal is to review the basics of magnesium and to understand the differences between total and ionized magnesium, and finally, to understand the patient's benefit of inclusion of ionized magnesium in the critical care testing menu. Why magnesium? Magnesium is sometimes called a forgotten electrolyte. However, magnesium is a natural antagonist of calcium. This means magnesium is playing a very important role under the shade of the calcium. Why magnesium is so important? Because magnesium is a cofactor for more than 600 enzymes in our body. It is almost all of the high-energy producing enzymes such as ATPase and creatine kinases. Magnesium ions will bind to negatively charged oxygen atoms of the phosphate, and upon cleavage of the phosphate bond, high energy will be released and the energy will be used for chemical reactions. Other enzymes related to biomessenger expression, free radical controls such as oxidase and lipid and carbohydrate metabolism related enzymes also requires magnesium as a cofactor. Orally ingested magnesium will be absorbed at the intestine, and then it gets into systemic circulations, and the major excretion organ of the magnesium is the kidney. When the blood concentration of the magnesium is high, reabsorption of the magnesium ions will be reduced. On the other hand, when the blood concentration of magnesium is low, reabsorption will be increased. And the major storage area of the magnesium as well as calcium are bones and muscles. This is a meta-analysis review article of hypomagnesemia and clinical outcomes in the ICU patients. Based on 10 studies and about 1,000 cases and 600 controls, they found out hypomagnesemia had a higher mortality rate, more frequent had sepsis, more frequent need for mechanical ventilation support. The length of the ICU stay was also higher in the hypomagnesemia group. Another meta-analysis suggested that for every 0.49 milligrams per deciliter, which is 0.2 millimoles per liter serum magnesium reductions, there was a 30% increase in cardiovascular diseases, which means hypomagnesemia is a risk for higher mortality. When the amount of catecholamine secretion increased, the lipid metabolism will be activated. The hydrolysis of lipids will release free fatty acid into the system, which has carboxylic acid group COOH. This COOH, COO- will bind to magnesium ion. Magnesium is captured and this is hypomagnesemia. The activated catecholamine production will cause blood pressure, renal blood flow, and urine volume to be increased. This will make lumen blood gradient becomes smaller, then magnesium reabsorption started to decrease. Magnesium is wasted to become hypomagnesemic. Both higher concentration and lower concentration of magnesium inhibits PTH, which will cause calcium ion shift from bone. Another disadvantage of hypomagnesemia is that the sodium-potassium ATPase does not work. Consequently, potassium ion will be left over in the extracellular space and excreted into the urine. This is part of the reason why hypokalemia is complicated with hypomagnesemia. So hypomagnesemia can be a trigger of other electrolyte abnormality. How about hypermagnesemia? This article from 2018 is looking at mean magnesium concentration of a day during ICU stay. The x-axis is days at ICU and y-axis is mean ionized magnesium concentration of the day. Mixed group means the patient showed both hyper and hypo status. Light pink zone represents normal range of magnesium. Magnesium level of hypermagnesemic patients were higher than normal even after 3 days. When you look at survival curves on your right, it was significantly worse in the mixed and hypermagnesemic group. You can see hypermagnesemia is also a risk for higher mortality. Therefore, monitoring of magnesium level is very important. When you see patients in hypomagnesemia, you give magnesium. 3 different words are used for giving magnesium: supplementation, depletion, and replacement. The replacement might sound soft to an ethics committee. A variety of salt forms of magnesium is available, such as magnesium sulfate, chloride, citrate, and others. The highest bioavailability can be obtained by amino acid glycine salt. There are various protocols for the magnesium supplementation. The key point is that if the protocol is good enough to reach therapeutic concentration, the reference range is 95% of the total population for normal adults, and within the reference range is not high enough to show efficacy. I will show you one successful example to treat tosadepoan later. For hypomagnesemia or accidental magnesium overdose, calcium gluconate will be used to expel magnesium from the cell. More urgent case, patient blood will be dialyzed. Now let's move to the difference between total magnesium and ionized magnesium. In the healthy adults, we have about 24 grams of magnesium in our body. The atomic number of the magnesium is 24, therefore 24 grams is 1 mole. About 50% of them can be found in bone, and the remaining half can be found in the muscle and soft tissues. Less than 1% can be found in the blood and in plasma. 3 different fractions of magnesium are under equilibrium. Ionized fractions we are interested in now, and magnesium complexed with negatively charged molecule and protein-bound fractions. The sum of all 3 fractions are called total magnesium, and the ionized fraction is the ionized magnesium. When you look at this in different figure, the ionized magnesium is under equilibrium with complexed magnesium and protein-bound magnesium. Proteins such as albumin and negatively charged molecules are phosphate, citrate, heparin, bicarbonates, and even lactates. The sum of the 3 fractions are total magnesium, and this is what you are measuring at the central laboratory of your hospital. However, among those 3 fractions, ionized magnesium is the only physiologically active fraction, and other 2 fractions cannot be participating any physiological reactions. The total magnesium cannot quantify each fraction. That is why you need measuring ionized magnesium. When the ionized magnesium and total magnesium are compared, they do not correlate well. It is because acid-base status of the patient changes all the time, and the pH also changes. Those pH changes will move the equilibrium of the 3 fractions. Increase of negatively charged ligands like lactate during hypoxia, and citrate by transfusion, bicarbonate by acidosis treatment, they all shift the equilibrium. Protein concentration in the systemic circulation also affects the equilibrium. So, how do you measure the ionized magnesium? You can measure it on Nova Biomedical blood gas analyzers. Ion-selective electrode for ionized magnesium and ionized calcium are equipped on Nova's blood gas analyzers, in addition to the gas parameters and metabolite like glucose and lactate. Unfortunately, blood gas analyzers from other companies do not have the ion-selective electrode for ionized magnesium, and they can only measure ionized calcium. Historically, total calcium was used in the clinical settings, and the albumin-corrected total calcium was later introduced. But the albumin-corrected calcium overestimates if the albumin was less than 3 grams per deciliter. So, many major hospitals moved to ionized calcium. Magnesium started with total magnesium, but the technology of quantifying ionized magnesium is available. There is no reason to wait. This slide shows the difference. This table summarized blood magnesium level and the corresponding clinical symptoms. Both milligrams per deciliter and millimoles per liter are shown here. Blue zones are the adult reference ranges. Depending on the study group, different number is used for reference ranges. But please remember, upper range of the total magnesium is 1 millimoles per liter. When magnesium level becomes higher, it usually asymptomatic up to 2 times of the reference ranges, which is 2 millimoles per liter. If the concentration further rises, you will start observing diminished deep tendon reflexes and drowsiness. If it exceeds more than 3 times, you start seeing electrocardiogram changes and hypertensions. If it exceeds 5 times, you will observe critical conditions like coma and cardiac arrest. Those are the toxicity of the magnesium. When magnesium goes down less than the normal ranges, hypokalemia and hypocalcemia will be observed. When further decreased, critical symptoms like seizures, tetany, and even tosa de pointes will be observed. What is ionized magnesium level? Some group estimates just multiplying the ionized fraction ratio, which is ionized magnesium divided by total magnesium. But as we have seen, equilibrium of the 3 fractions shift and it is difficult to estimate ionized magnesium. Therefore, we have to measure directly. This article measured both total magnesium and ionized magnesium of the same blood from the consecutive 44 patients who were admitted to ICU and 3 primary health centers. X-axis is ionized magnesium and y-axis is total magnesium. The yellow zone is normal range of total magnesium and the vertical dotted line is the zone for normal range of ionized magnesium. This means the patient in the red circle, 25% of the patients were normal by total magnesium, but actually hypomagnesemic by physiologically active ionized magnesium fractions. You might miss those hidden hypomagnesemia if you use only total magnesium. You can understand total magnesium does not always reflect physiologically active concentration of magnesium. The next article is comparing ionized magnesium and total magnesium during cardiac surgery using cardiopulmonary bypass. The white box is the total magnesium and the hatched area is ionized magnesium. Total magnesium on your left side increased up to 0.73 millimoles per liter 24 hours after operation. But when you look at ionized magnesium, it went down to 0.18 millimoles per liter, which is very low. You can clearly realize that if you are looking at only total magnesium, you might miss this kind of hidden hypomagnesemia, which might be linked to a high incidence of postoperative arrhythmia. Interestingly, ionized calcium and total calcium changed parallel. Next one is from the United States, Massachusetts General Hospital, Surgical ICU. Similar to the previous study, they plotted ionized magnesium and total magnesium, and then they identified hidden hypo and hidden hypermagnesemia. Very interestingly, this group has calculated the economical impact by switching from total magnesium to ionized magnesium. About 20,000 US dollars for unnecessary magnesium test and 2,600 US dollars for unnecessary magnesium sulfates were identified. In total, during the study period of 3 months, they could have saved 22,600 US dollars for one surgical ICU. The hospital has 2 surgical ICUs, and the annual savings could have been enormous. The next one is from Japan. They are comparing ionized magnesium and total magnesium during operation when they used two different infusion solutions with different magnesium contents. Magnesium contents in one of the infusion solution was 1 millimoles per liter and the another is 0.5 millimoles per liter. The total magnesium level of both infusion solutions used up to 3 hours after operation are within reference range. However, looking at ionized magnesium on the right-hand side, the infusion solution used with 0.5 millimoles per liter were lower than the lower limit of ionized magnesium reference range. Even higher content infusion solution used, ionized magnesium level was close to the lower limit of the ionized magnesium reference range. This comparison tells the ionized magnesium needs to be measured for what actually is going on with your patients. The next article is from Pediatric Cardiac Operation using Cardiopulmonary Bypass. Magnesium sulfate or placebo was administered during the rewarming phase of the CPB. The groups were divided into 3 groups: placebo 25 milligrams per kilo or 50 milligrams per kilograms of magnesium sulfate, Endpoints was the incidence of hypomagnesemia and incidence of junctional ectopic tachycardia (JET). The incidence of junctional ectopic tachycardia (JET) was 17% for placebo group, 6.7% for 25 mg per kilo group, and the highest dose group 50 mg per kilogram showed no junctional ectopic tachycardia. Patients' magnesium level were monitored by ionized magnesium. The yellow zone is the reference range of ionized magnesium, and let's look at the graph more in detail. The ionized magnesium of placebo group was within the reference range, and the raising slightly to 0.73 millimoles per liter of the ionized magnesium reduced the incidence of JET by half. Even to the 0.92 millimoles per liter with 50 mg per kilo group did not show any JET. Remember, up to twice as high to the upper limit of magnesium reference interval, it is typically asymptomatic. This 0.92 millimoles per liter is below the upper range of ionized magnesium reference range. We are in the safety zone in terms of toxicity. So, keeping within normal range is not good enough to prevent JET, but we do not want magnesium toxicity. In these cases, monitoring of physiologically active ionized magnesium is suitable. In the last section of my talk, I will show you 5 key ionized magnesium publications from 2020 to 2024. The first publication is from Department of Anesthesiology, Dr. Koyama's group from Saitama Medical Center, Japan. Saitama Medical Center uses 6 units of Nova's blood gas analyzers, including general ICUs, emergency department, hemodialysis center, and delivery room. They are always measuring ionized magnesium. In this article, this group have identified 5 different risk factors for postoperative atrial fibrillation after coronary artery bypass grafting. Those are the factors as you can see on the slide. If they have more than 2 factors, the risk of postoperative atrial fibrillation increases. The second article is from case report, also from the Saitama Medical Center. When they had a patient with tosa de pointe, they treated the patient with magnesium sulfate by the monitoring of ionized magnesium. Tosa de pointe terminated when the ionized magnesium concentration reached 1.31 millimoles per liter. Then, the target ionized magnesium was set to 1.3 millimoles per liter. The ionized magnesium concentration was measured every 2 hours to adjust the continuous dose of magnesium sulfate. Dr. Koyama's group knew ionized magnesium of 1.3 millimoles per liter was still safe dosing amount while monitoring blood ionized magnesium level. They also knew it was typically asymptomatic up to 2 times as high as the upper limit of the reference values for total magnesium. 1.3 millimoles of ionized magnesium should be safe. By monitoring ionized magnesium for the treatment of the tosa de pointe, magnesium can be administered to the patient even with low renal functions as far as the blood ionized magnesium levels are properly monitored. Analogous to the treatment of Tosa de Poin, Saitama Group reported a case for the treatment of severe preeclampsia by targeting below 1.34 millimoles per liter by ionized magnesium, which is twice the upper limit of the ionized magnesium reference interval. The patient was treated with continuous intravenous infusion of magnesium sulfate at 1 gram per hour, and ionized magnesium was checked every 3.5 hours. After 17 hours, the dose was reduced to 0.5 gram per hour in order to keep the ionized magnesium level below 1.34 millimoles per liter. The patient had a recurrence of seizures during operation. However, this type of approach, which is setting target level of ionized magnesium and serial measurement, can contribute to the management of the severe seizure in the ICU. Postoperatively, the patient was managed with continuous magnesium sulfate infusion under bedside ionized magnesium monitoring using blood gas analyzer in the ICU. Author says this approach might have helped prevention of further seizures and complications associated with administration of magnesium sulfate, such as hypomagnesemia. The next article was published in 2021. They looked at the relationship between ionized magnesium and shivering after pancreaticoduodenectomy. By retrospective statistical analysis, they found pre-surgical ionized magnesium was not significantly associated with post-operative shivering, and decrease in the ionized magnesium during surgery was significantly associated with post-operative shivering. They found subjects who had ionized magnesium lower than 0.6 millimoles per liter post-surgery and decreased ionized magnesium during surgery had a significantly higher risk of post-operative shivering. The next 2022 article is from Korea. They evaluated the relationship between ionized magnesium level upon arrival at ICU and acute kidney injury after cardiac surgery. The ionized magnesium level before they go to the operation room were categorized to divide into 4 different groups from low to high. After multivariable logistic regression analysis, they found that the low ionized magnesium level before the cardiac operation was associated with the incidence of AKI. The take-home message from this publication would be testing blood magnesium levels before surgery may help to identify patients who are likely to develop kidney damage after heart surgery. The reduction in kidney blood flow due to the hypomagnesemia might be a reason for this result, as well as CPB-induced kidney ischemic reperfusion injury. The next article is discussing about correlation of ionized magnesium and total magnesium in the ICU. The blue circles are patients in the general ICU. The red square is patient who had continuous veno-venous hemofiltration, CVVH. Determination coefficient R square for blue is 0.90. This is pretty good, and the correlation of ionized magnesium and total magnesium of the patient in the general ICU is very good. On the other hand, the red square CVVH patients matching of categorization was poor. This was caused by the formation of magnesium citrate complexes that are measured in the total magnesium assay, but not in the ionized magnesium assay. When citrates are used as an anticoagulant for CVVH, ionized magnesium can identify if magnesium supplementation is really needed. This is not an ionized magnesium, but total magnesium and delirium. This might draw your attention, and I will show you as one of the potential research topics in ionized magnesium. Patients who stayed in the ICU more than 48 hours were divided into two groups based on the median of the total magnesium upon arrival to the ICU. The median was 1.7 milligrams per deciliter, which is 0.7 millimoles per liter. The incidence of delirium was 32.1%, and hypomagnesemia was independently associated with delirium with hazard ratio of 2.12. Other associated factors were immunosuppressant use, benzodiazepine use, or alcoholic history. Red line is hypomagnesemic group and black is normal total magnesium group. The cumulative hazard is much higher for the hypomagnesemic group. It would be very interesting if the similar analysis was made based on the ionized magnesium. This is the conclusion of my talk. The monitoring blood level of magnesium is important when magnesium is supplemented or magnesium-containing cardioplasia is used. Ionized magnesium can be measured by a blood gas analyzer. Clinical decisions should be made based on ionized fraction rather than the total magnesium level. The measurement of ionized magnesium and the correction of ionized hypomagnesemia contribute to the prevention of postoperative cardiac arrhythmia. The inclusion of ionized magnesium in the critical care profile enables rapid assessment of the physiologically active and clinically relevant fraction of magnesium. This is my last topic. The importance of ionized magnesium is finally described in the Clinical Practice Guideline. September 2024 Guidelines on Myocardial Protection in Open Heart Surgery was published. This guideline was the joint publication of the 5 different related societies shown here. Currently, this guideline is only open to the society members. It is password protected, and the guideline is written in Japanese, and the English version will be prepared soon. If I could highlight the section where the ionized magnesium is described, that would be Chapter 7, Intraoperative Monitoring and Perioperative Management of Myocardial Protection. This is unofficial translation, but it says only ionized magnesium is considered to have physiological activity among the serum total magnesium. It also says, therefore, direct measurement of ionized magnesium as well as ionized calcium is considered important for detecting true serum magnesium abnormalities, and real-time measurement of ionized magnesium concentration is desirable for setting target values of magnesium correction for the prevention of postoperative arrhythmia and for determining the efficacy of treatment. This is the end of my presentation, and I hope you can see the benefit of having ionized magnesium bedside of the ICU patients. Thank you.
Okay, and thank you. We'll move to the question and answer session now, component of this webinar. A number of questions have come through. It's wonderful to have had the support and participation of well over 60 attendees for this evening's webinar. Clearly, there's a high level of interest in this topic. Thank you, Masaru, for your presentation, and welcome. How are you? Nice to see you on screen. I hope you can hear me okay.
Yes, I can. Thank you very much, Steve, and thank
That's
you
great.
very much for attending the seminar.
Thank you. So, Masaru, there are a number of questions that have come through, and
Mhm.
I'll work through those with you if we can. We have 15 minutes. The first one that I would like to present to you that came through during the presentation
Mhm.
was actually this. Is magnesium the same in both arterial and venous blood?
Okay, it is a good questions. It's clinically speaking, both arterial and venous uh, doesn't show any clinical difference, just like other electrolyte in the blood. But when I don't think anybody in the audience take care of the neonates. In the case of neonates, umbilical um, umbilical venous, which is adult mothers, uh, which it's complicated. Sorry, umbilical venous is the umbilical venous is which one? Sorry, I'm lost. But umbilical venous is the maternal artery, right? So maternal artery is equal magnesium level of the maternal artery will be equal to the umbilical umbilical venous, and so in case of the neonates are a little bit different. Difference are reported, but I need to check the difference again. Sorry, guys. I'm completely
That's fine. And with these
mixed.
questions, yeah, we will revert back as well to the people that have answered them as we work through them too
Yeah.
with these answers. Not a problem. I'll move on to the next one, Masaru, if I may, which is a question about where ionized magnesium is useful other than in intensive care units or emergency departments. Where else do you see this as having use?
Okay. Other major department would be OBGYN department, because magnesium sulfate is massively used for the treatment or prevention of eclampsia or preeclampsia. So that would be OBGYN department.
Okay. Okay. Thank you. Thank you. So moving to the next question, which has come through here, we've been asked, and I don't know if you're in a position to comment, but the question is, um, would you know what is the best oral form for magnesium replacement?
Best oral form.
Mm,
I think it was included in my presentation, but the magnesium salt of the alanine amino acid magnesium salt will give the highest bioavailability among the magnesium salt, which is not usually used for medical use. Usually it is used for like foods or nutrition. So maybe you can buy at on the internet, but as I said, magnesium salt of the amino acid is not not categorized as medicine. So, but that gives the highest bioavailability.
Okay, thank you. You mentioned in your presentation about the how Japan has made moves to include ionized magnesium in certain guidelines. Is ionized magnesium commonly used elsewhere in the world or in any part of the world? Perhaps you could comment from your knowledge.
Yes, because Nova Biomedical is a worldwide company, so we have a business everywhere. But in terms of publications, I think now many studies out of Europe coming out, and so we are paying attention to many new research for those publications comes from Europe. Of course, in the United States, yes, we have various many hospitals are using our blood gas analyzers and measuring ionized magnesium. So number of the publication is increasing in the past 3-4 years. So it will be very interesting to see more evidence that monitoring ionized magnesium is important.
Okay, yes. So there's a increasingly rapid uptake of ionized magnesium testing. Next question I have here, Masaru, is: does having ionized magnesium available on the analyzer actually create much additional cost to running the blood gas panel? I may be best placed to help comment here as well, given that I have more of a commercial role, and insofar as we can share the panel, the standard panel on the unit includes ionized magnesium. It is a standard test, and so therefore there is no additional cost for running that test. Is there anything you'd like to add to that, Masaru?
In addition to the cost, analysis time is also no difference between the blood gas analyzer with or without additional ionized magnesium parameter. So the cost is the same.
Yeah.
The analysis time is the same.
Thank you. And you kind of anticipated the next question, which was with regards to the running time. So thank you for that and clarifying that. That's great. So thank you very much for answering those questions. Those are the questions that we have that have come through this evening. Thank you to everybody who's participated and sent through those questions. Masaru, it was a pleasure having you talking this evening, and really appreciate your time. And look forward to working with you again. To the people who are on the call, please know that Nova Biomedical is very grateful for your participation. We will follow up with you in case you have any further questions, or we can help further. In addition, a feedback form will be sent to you, as is generally the case after events of this nature, to the email address that you used on registration. Please, it does really help us. So we would welcome your feedback as we continue to develop this education program across 2025. So if you could complete that, that would be wonderful. And so therefore, that concludes this evening's webinar. Thank you very much for joining us, and have a very good evening from New Zealand.
Thank you, everybody.